Okay, great. Good morning, everyone. Welcome to the fourth Rules Advisory Committee meeting for House Bill 3046, Mental Health Parity. I'm Lisa Emerson. I'm a policy analyst with the Division of Financial Regulation. Again, welcome RAC members, interested stakeholders, and division staff. If you would just please refer to your agenda and we'll go ahead and get started. And I'm going to start with a brief recap of the RAC meeting number 3. And then we'll move on to asking for those of you that have submitted comments, written comments recently to briefly summarize those. But just to briefly recap, we mostly discussed a recap of the previous meeting. We also allowed those that had submitted formal comments to summarize those briefly. And then we jumped into reviewing the draft discussion rules. And that discussion centered around the discussion of defining incentive payments. And this is all with respect to the reporting for mental health parity, which has been the focus of this rulemaking, is working out the reporting requirements. We discussed the form and manner for behavioral health benefits reporting. We discussed denials, including what would be a partially approved claim. Discussed behavioral health benefits data reporting for the median maximum allowable reimbursement rate to include provider contracted rates and actual incurred claims data. We discussed the other data that would be necessary to assess compliance with state and federal mental health parity laws and rules. Thank you all for your verbal comments and feedback, as well as all the formal written comments. And before we ask those of you that recently submitted comments to briefly summarize them, I will go ahead and introduce Cassie and turn over to her if anything she'd like to share before we jump into the next agenda item.
My only reminder to all participating today is to make sure that you're on mute if you are not speaking, just to make sure that we reduce any background noise. Thanks, Lisa, for giving a good overview of what our last meeting was about. And we're hoping that with this meeting, we can kind of get to a spot where we feel like there's relative consensus with the reporting requirements, and so that we can move on to kind of the other components of House Bill 3046, which I know some RAC members have been patiently waiting for our discussions on that. And so I appreciate your patience as we kind of work through the reporting requirements and get those moving, and then we'll transition to all of the rest of the bill, which is quite a bit of work ahead of us. So with that, I will go through the list of folks who provided comments for you to kind of summarize or explain a little bit further in brief. So we'll start with Chris from NAMI.
Yeah, thanks. Well, I mean, I think the comments speak for themselves. The general gist of it is, what reporting on the Federal Parity Act and on Oregon's parity statute changes in a sense as of 2023, and there are components required, particularly in Section 8, but elsewhere, that should require some reporting on some regular interval, whether that's annually or some other interval. And those are the key components around, as is said in the comments, around level of placement criteria, but also the other criteria utilized for non-level of placement decisions and how they are publicly accessible.
Great, thank you, Chris. Moving on, we received comments from Jen at Providence.
Hi. So our written comments were, for the most part, a reiteration of some of the things I talked about in our last meeting. We are concerned about the unintended consequences of requiring both the contracts and the incurred claim rates for the time-based office visit billing codes and the annual reports. We recommend that you not require, if you are going to require the contracted rates, that you consider not requiring us to include contracts with providers who have seen no patients, because I mean, that is going to be a very time-consuming, very high administrative cost for health plans, for something, for a provider that hasn't seen any patients. And so I really think that it goes against the legislative intent of 3046 to provide an accurate reflection of what our current contracted rates are with these providers. And then I'm just looking at my at my comments again. In the subsection 3B5, it states you need to, the DFR is asking health plans to provide descriptions and document on policies, procedures, and other efforts to maintain compliance with federal mental health parity laws. And we feel that this is a little broadly written. We just want you to clarify that this language is aimed at policies and procedures related to reimbursement issues, which is the purpose of that section. So if you could have language that clarifies that, that would be helpful. And then in 3B6, the DFR requests policy, procedures, and other efforts to maintain compliance with state mental health parity law, and that statutory language has broad requirements that go beyond the NQTL analysis that's required in HB 3046. So you're kind of going beyond the statutory authority. So we ask that you modify that language to include providing descriptions and document on policies, procedures, and other efforts to maintain compliance with NQTL's applicable under 743A 168. And then last, in 3B62A, the DFR requests an assessment on health plans' behavioral health provider networks meet standards of the broader network adequacy state statute, including steps taken to provide a diverse network of providers to their enrollees. And we just find that redundant to the broader network adequacy reporting that's required, and it does not speak to the actual NQTL analysis, which analyzes comparability and in development and application of mental health and substance abuse disorder network compared to the medical surgical network. So we ask that the DFR clarify that that is the intent, and the rule be better defined to clarify the health plans are to reference their annual network adequacy reporting rather than broadly referring to the statute of 743B 505. So that's more specifically what our comments are, and we're happy to discuss further.
Thank you. We'll move on to Rachel from COPACT.
Hi, thanks. We had two just short comments, one noting our appreciation for the inclusion of the network adequacy piece in the reporting, and how much we're looking forward to that discussion. As a reminder, network adequacy reporting doesn't really mean much if you don't have strong and clear network adequacy requirements. So sort of sharing our enthusiasm for that discussion. And then we just wanted to make sure to go on record in support of the inclusion of the contracted rates that was discussed last meeting and brought up so well in OIMHP's memo. Could providers make decisions to join networks based on the contracted rate, not the incurred claims data? And so it's just really important that that be captured in the reporting as we're really trying to judge whether or not parity is being accomplished. Thanks.
Thanks, Rachel. And then we'll move on to Melissa.
Thanks. Well, we had a number of small things, but I wanted to just focus on a couple of things that we feel strongly about. And so, we just wanted to reiterate that we continue to feel pretty strongly about the inclusion of contracted rates data and that we would be fine with that alone or with both contracted rates as well as incurred claims, and that looking at both might give DCBS the opportunity to make some interesting comparisons. So in general, we support the revisions that were in the last draft rules, which I think are still the same in 3B3, 1 through 3. And I also just wanted to put it in, and we also wanted to put it in writing, some of the comparisons that we are interested in with as far as the MMARR goes, and those trends in time-based office reimbursements year by year, kind of being able to look at mental health in comparison to medical, surgical, and kind of seeing, are we seeing the same sorts of increasing or decreasing trends year after year? And then we're also interested in trends of reimbursement increasing as time-based office duration increases. Do we see similar trends there? And then, of course, already specified in the bill is looking at the reimbursement rates of different provider types as in comparison to Medicare allowed amounts. So that, and then our other thing, we did want to make clear that we support the additions made in 3B6, which specify more clearly the requirements for carriers to report on network adequacy and reimbursement methodology. Thank you.
I'm just listening to a meeting.
Oh, can we make sure that folks are muted? All right, so thank you everyone who submitted comments. We really appreciated it, and we took our time going through what was submitted and considering kind of the suggestions and changes that were within those comments. All right, so before we launch into our discussion of the rules, one of the important kind of process milestones, I guess, is for us to talk about the statement of need and fiscal impact. And this is an analysis that is required for any rulemaking that the department goes through or any agency goes through. So really quickly, I'll walk through what we have in here, and then there's a couple points for questions for the RAC to respond to. Oh, Jim, did you have a question? You're on mute.
Yes, this is Jim. I'm Jim Davis, Senior Disability Advocate and member of the Insurance Advisory Committee. You may have covered this in some way before, but my interest in with some of my advocates is once all this data is collected and the reports are in, and I know it's all public, but is there going to be a process by which it is going to be deciphered in a way that consumers and the public will understand and reported back to the public on a consistent basis? I know that was brought up a little earlier. I'm just kind of confused how this is going to be reported back to the public so that we can understand what is fairly complex at times.
So the division is required to submit a report to the legislature annually on this data, and hopefully that will, we'll be using plain language and kind of having the rolled up analysis of all the data that we do receive, and that we generally post all of our reports on our website that are required by the legislature, so it will be publicly available on our website for folks to take a look at.
Thank you.
You're welcome. All right, so one of the things that, to go back to the statement of need and fiscal impact, or as many people like to call them, SNFIs, which is a fun acronym, we start with kind of explaining the need for the rules, and this provides kind of an overview, a summary of why the rule is needed and the applicable parts of the law, which mostly is to provide clarity on the form and manner for reporting behavioral health benefits. including defining vague terms and further clarifying data elements that insurers will be reporting. Do any of the RAC members have any comments about that section, the need for the rules? It's pretty straightforward and self-explanatory, but if you do have any comments, let us know. The next part of this is that kind of analysis of fiscal and economic impact. And overall, based on the information that is available to the agency, our understanding is the proposed rules would not have any additional fiscal or economic impact on state agencies, local governments, the public, or small businesses beyond the underlying statutory requirements, which do have a fiscal impact. So moving on, it goes through kind of some sections that we'll go through. Like I said, in summary, we don't think that there is a fiscal impact on state agencies, local government, or the public, but want to open that up for discussion if any RAC members have any thoughts that are different than that or information they want to provide to the agency that'll help with our understanding. All right, hearing none. The next part of the analysis is the cost of compliance on small businesses. Part of this is to estimate the number of small businesses or types of business and industry that are small businesses that would be affected by the rule. And as far as we know, based on kind of our knowledge of the insurance industry, is that it's unlikely that any insurer subject to these reporting requirements is a small business. We do talk about that there possibly are costs for compliance that insurers will have to incur around administrative activities or the projected reporting, or on kind of the equipment, supplies, or labor to do this reporting, but want to ask the rulemaking advisory committee if that seems accurate to you all, if there's any other information regarding small businesses that would be impacted by this reporting. It is primarily for insurers, so like I said, to our knowledge, we think it's unlikely that any insurer is a small business. I'm going to take silence as agreement on that statement. That is basically the SNFI overall. It kind of walks through those points. If you do, thank you, Rick. Yes, a small business means 50 or fewer employees, to provide that kind of clarification. So if you do have any feedback on the SNFI, please let us know. This is part of our rulemaking documents that will be formally filed when we move this rule forward. All right. If there's nothing else on the SNFI, we will move forward and start our discussion on the rules. I think, like we said at the beginning, our hope is that we can come to some find some relative consensus around the reporting requirements so that we can continue moving these in the process and have them in place for insurers to reference as they get ready for their March 1st reporting. We'll start with the definitions section. And I know that there were some comments of Melissa that you had about including a definition for the median maximum allowable reimbursement rate, and that we've defined geographic region. And so while we included kind of this definition for geographic region, it was mostly for clarity purposes of just referencing like this is what we will be using, which is in relation to the statutory definition. It's just kind of clarifying that point. I'm not sure if you had thoughts about kind of what you meant by defining the median maximum allowable reimbursement rate. I don't think we can like change or amend it, but we can provide clarity on how that's reported in further down in the rules, but wanted to hear if you had anything more specific about that.
Not necessarily. I just noticed that it was absent, and it has been such a topic of discussion. And so all of this is pretty new to me, and it was more a question that I posed of whether it makes sense to you to include it in the rules, or whether you think it's sufficient what is already in the bill.
All right. Great. Yeah, I think we'll stick with. Oh, Bennett, did you have something?
Well, I have a question. Every time I see geographic region mentioned, I find myself wondering, how does telemedicine factor into this? Have you all thought through that? Or has anybody thought through that?
So this is Tasha. I guess I'll start. My apologies for the record, Tasha Sizemore, Life and Health Program Manager, and I'm not going to be on video today because I'm outside huddled up in a sweatshirt listening to this call. The telemedicine question is a good one, and that's something that I've been looking at in relation to our network adequacy reporting as well. So previously under our rules, there were allowances related to telemedicine and allowing an insurer to use CMS had a 10% like allowance if insurers use telemedicine to meet network adequacy and to meet those areas. That has been removed under network adequacy. So as I'm looking around at the issues around telemedicine and access and coverage, so I would first of all look back to the new telemedicine bill, and I'm blanking on that. Maybe Cassie has that one on the tip of her tongue. But I would be looking back at that for how it regards reimbursing telemedicine going forward. And then I am going to ask insurers about how they use telemedicine to supplement access, but it cannot, it can no longer under Oregon law go to fill that 10%. So that is something I'm thinking about. It's a great question, and I am always up for a conversation. I don't know if we have time today, but as we kind of talk through that, I'm always up for conversation about how we should be looking at telemedicine because it's something I'm aware of.
And thank you, Dan, for providing the bill number. I think it's House Bill 2508 on telemedicine.
Thanks. And when Bennett asked the question, what it made me think of was, when we're reporting median maximum allowable by region, if the patient is in one region and the provider is in another region, which region does that claim get assigned to?
So I guess I would have a follow-up question to your question about how often that happens. I imagine it could be frequent or it could be infrequent, but how often is a consumer kind of receiving care from a provider that's in a completely other region? It probably, I think it would be helpful context to this conversation.
It's a great question, and I don't know. I would say wild guess, probably less than 25% of the time, but I don't know if it's 24% or 3%.
I guess,
I would also suspect that it might vary by provider type, right? Because I would imagine that psychiatry might have a higher percentage than master's level therapist. I don't know that. The other question I would have is, are you paying the provider a different rate based on where the patient is?
From our perspective, that's the clear no. It's the same regardless where the patient is.
That's the same for Providence. I just wanted to clarify that.
so this is Tasha. Oh, Gary, go ahead. I think you were trying to talk.
I was going to say, I agree with what Jen and Tom said for Pacific Source.
Okay, so I mean, I think what I'm hearing here is this may be something Spencer and I can work out in the reporting template. But it sounds like something that Spencer and I should have some kind of an answer for. So I think he's on the call today. If not, I can take this back to him and we can work this out, I think. A very helpful context. Thank you so much.
Yeah, and we did include further in the rule and the like other information and data required for compliance. There is a section on telemedicine and telehealth and kind of how that looks in this space. But I think it's a good point of should this be integrated into how we do that geographic region and the time-based office visit reporting. Like Tasha said, we're planning on having another conversation potentially or some email traffic about the templates, and we'll definitely send it to you all to take a look and provide feedback after we kind of move forward in this process with these rules. And like any new reporting, we will likely still be in rulemaking after March 1st of next year. And so if we run into any kind of roadblocks or places where we do need clarity in the rule, I think we'll have an opportunity to come back and make any changes if they are needed. But appreciate this conversation and bringing up the nuances of telehealth, and especially because it's more in use now than it was probably previously. And so it's an important point for kind of this evaluation and reporting. All right, so we'll go on to, I know we had some questions about the incentive payment and we had some conversation about how that looks. I did remove the language that was about, you know, kind of if it limits a benefit or whatnot, but how does that look now? Does that describe an incentive payment generally? Is there anything else that needs to be included? All right, I think I saw some nodding heads that looks okay. Okay. If there are any issues, if you take it back to your team, let us know so that we can make those changes. I don't think there were any changes to partial denial or a time-based office visit. Those look the same. And so we'll move on to the form and manner for reporting. And we'll skip past the part about the federal reporting since most of our conversation is focused on these other data elements. Gary, yes.
Did we ever finalize a template design? I know that was at issue before.
We haven't finalized a template design, but that isn't necessarily required for the rules to keep moving forward. Our plan is that we'll have another meeting where we'll talk about the templates and get that feedback from you all, since the rules give that flexibility to us to kind of put together that template.
Okay.
Mm-hmm. All right, so we'll start with we'll just kind of walk through all of the elements. The first is denial information. I think we have had some good conversations about this. I don't know if there's anything else, but want to kind of open it up and see if there are any other pieces to this that need to be further clarified. Okay, seeing none. And Gary, your hand is still raised, but I think that's from the previous. Okay, just want to double check and make sure. All right, so we'll move on to number 2, which is the percentage of claims paid to in-network providers and out-of-network providers. I think we had this question and conversation about a partial claim, and it's our understanding that some carriers do use the terminology of a partial claim, and so we're going to keep that language in here just to make sure that we are capturing all types of claims that are being paid to providers as part of our analysis. Any feedback on that one? All right, hearing none, we'll move on to, I think, the data element that has captured a lot of our discussion, which is median maximum allowable reimbursement rate, and really we can spend the time that we need with this. I think we're doing well on time, and I know this is an important piece for this reporting. So we are planning to keep both the provider contracted and the incurred claims reporting as part of this median maximum allowable reimbursement rate. And this is because, the purpose of this reporting is to further our understanding of mental health parity. And from the comments that we've received, it sounds like that both are going to be important to our analysis as a division about mental health parity. Kind of to some of the comments that were made about like skewing numbers or things like that, it might be helpful, and I would love to get the RAC members' feedback if we get a report of the number of providers who do have zero claims experience to help with that context. I think some of that will probably be captured in the incurred claims rate, but if we want to make it more accurate, we can require the reporting of that number. Any thoughts? Jen?
Yeah, I mean, I just wanted to reiterate that incurred claims is the contracted rate. I mean, and so I don't understand necessarily why we need to have both, but I mean, if we can go ahead and dig through, I think it would be, again, time consuming to dig through to find out who has not had any claims data for the current calendar year, but we can certainly try, and I can request that and see, how often that occurs.
Any other kind of thoughts about that, or I guess I'll open it up generally about this section and see if there are any places that we need to focus on. Gary?
Yeah, I was trying to say what you were just saying about, report if you have 0 providers. Can you give a little more of how would you use that? Because of all the carriers, we may contract with the same provider, those numbers are going to get thrown around a little bit. So I'm trying to understand how that's going to provide clarity or help you in your analysis.
So my thought was that if you're worried about the skew of the provider contracted rates and including providers who have 0 claims experience, kind of moving that median, I guess, lower, right? You could include like the number of the providers that do have 0 claims experience to provide context to, right, like why it's shifted lower, perhaps.
Well, but you're still asking for the information. It's not like anything's being removed or subtracted. Because we're gonna have to include incurred plus contracted rates. And then we're just gonna tell you out of all that median amount, there may be 50 providers that never submitted a claim. I'm just not getting the connection there, how that will help you.
So Gary, I have an echo. I think that from my perspective, that's something that I'm really interested in, to understand, how many providers don't have incurred claims. From the network adequacy reports, I get, or I understand that some insurers may already be collecting this information, whereas other insurers aren't. Like some insurers might run a report to see how frequently a provider has had a bill, and if they haven't been very active, that some insurers might do outreach to that provider. So I just want to say, like, there's a host of ways that different insurers do this, and I think that by giving each insurer kind of an opportunity to have that reported to the division, that gives us an opportunity to have a conversation with you guys, and also for you guys to look internally. So I see a lot of value in it, and I think it would be a good addition.
Okay, thanks.
Yeah.
Any other comments or questions about median maximum allowable reimbursement rate? I know this is a new reporting element for you all and for us. Hopefully this provides some more context to help with that reporting. Gary.
Hey, one minor issue is I saw that in this section, we didn't do the same as we did in section 4. We said that the CPT codes are going to be provided on a division's website. We need to add that piece in there to be consistent.
It is included in the upper, like the 3 overall. I can put CPT.
Oh, sorry. Okay.
It's all good. Yeah, no, we
Okay.
definitely want to make sure that there's some consistency, and we'll make sure, kind of internally, that if there are areas where those CPT codes should be listed, we will make sure that they are listed.
Right. Sorry, I didn't pick up on that.
It's all good.
Thank you.
Yep. Melissa.
Yeah, I do have a question about what I had said when I was summarizing our written feedback, is just the specific comparisons that I put in my written feedback. Is that something that needs to be put into these rules, or does that come out in the templates? Maybe Tasha can answer this question, but those are the comparisons that we as a group are really concerned with. And I am just wondering, does it need to be put in writing somewhere, or how is that going to work?
So I would look to Cassie for the legal or the rule requirement around that. Cassie, would we need that in rule? I haven't sat down to go through, just so you know, or just so the committee knows, I haven't sat down to go through and list out all of the analysis that I would like my team to perform on this. I think that I'd like these conversations to kind of finalize before I fully devote my time to thinking about that. So I haven't really sat down and seen how to evaluate how those fit within the other analysis that we're going to do. But Cassie, would we need to codify that, or would that just, I feel like that would just be kind of internal procedures that my team would use?
Yeah, I think you're right, Tasha, that we wouldn't necessarily codify that in rule, because this is mostly about the form and manner for reporting, that the insurers will be reporting, and providing that clarity. I think that feedback is helpful as we design the templates for reporting, and think internally about what analyses would be helpful for evaluating parity. In particular, what legislators are looking for, what other stakeholders are looking for out of these reports. So, or the report that the division publishes.
Thanks for clarifying that.
The one other thing I will note on median maximum allowable reimbursement rate is I did make the language about incentive payments more in general, just to include a description of how they were factored into the calculation. This could be as simple as just kind of briefly explaining it, or if it ends up being more complicated on your end, I just wanted an opportunity to provide context to like how the calculation was made, and if there's any kind of things that should be flagged for the division to know about incentive payments, since they're specifically called out.
Yeah, I like that language. I think it's I think it hits the mark.
All right, before we move on, is there anything else with median maximum allowable reimbursement rate? All right, hearing none, we'll keep moving through to the time-based office visit. I think there were some comments about this. We did include kind of that specification that the CPT billing codes will be identified on the department's website. So thank you for pointing that out so that we can make sure that that is specified in rule. There was a question about the calculation for the percentage of Medicare rate. The intention of this language is to, make sure that the medians are being calculated when you do that comparison. I know that Medicare billing can be different. So if this language doesn't make sense, or if we need to kind of work with some different language, I'm happy to hear that feedback. Dan.
I think it would make sense to remove the word median before Medicare. So it should compare the Medicare rate to the median maximum allowable. Because that median maximum allowable applies to us and what we pay where there's a range. But I think we want to compare that to a fixed amount of what the Medicare rate is, and not, there could be, like if you apply GPCI or something, you could get different Medicare rates, but I think that would just get really, really mucky really fast and not provide any additional clarity.
And Lisa, you have your hand raised.
Yeah, I did a little research on this question because I wanted to know for myself, so I could add to this conversation. And I went to the CMS physician fee schedule search tool, which is pretty robust on the CMS website, and I put in a behavioral health code, and to understand the geographic issues, the geographic billing issues with Medicare, and it does appear that there is a modifier to a rate of reimbursement for Portland versus all the rest of Oregon. So I think you could come up with a median, some kind of number that might add value to be, but I think we all understand that Medicare typically reimburses lower than commercial insurance. So that's just something that I did some research on, and you could come up with a median for the Medicare reimbursement rates. Whether that adds value or not, I don't know.
Thanks, Lisa. I think if anyone else has any, Gary, yes.
Well, I agree, Thomas. I think it's good because either it could be the median of the geographic rate or the median of the state. So I think if you clarify it. because they have those modifiers. So I think that's good.
Yeah, we'll kind of think about that with knowing that there's the geographic modifiers to the Medicare rates. But yeah, I know that it's usually just a kind of single number, at least my understanding. Melissa.
Yeah, we were one of the people who just raised the question because the way that it's written, it does specify the median rate by each geographic region. And our understanding is that there may be different Medicare rates within each geographic region. You know, so Portland, for example, in that map that you gave us previously is a geographic region, and that might be different than what the Medicare rate is in Eugene, for instance. So I guess it does make sense to clarify whether you're going to have different Medicare rates in each geographic region, which is how it appears to be written now. And in that case, median might not be applicable. But if you are going to come up with just one for the entire state, then it seems like it would be applicable.
Do RAC members have kind of opinions about whether we use the median for the state or the specific geographic regions, knowing that there's probably only two, Portland and not Portland?
Cassie, it's Jen Baker, and I would just want to check in with my people before I get back to you on that. But if we have comments, I will submit them.
Sounds good. And yeah, if you all need to take this back to your teams who know more about Medicare rates and how they work, that makes a lot of sense. But we would appreciate that feedback about how we can best kind of calculate that. And if this language makes sense, and if we just need to clarify some pieces in the template, that's also another option. But we'll look forward to getting that feedback on this piece, so that it's clear about kind of how to report that data element. All right, so we'll keep moving on to the next one, which appreciate that it was pointed out that the statutory reference for this reporting element does relate back to the NQTL analysis. So we've made changes to reflect that. And I think this will be mostly supplementary information if there are any policies, procedures, or kind of descriptions of those things to maintain compliance with the NQTLs. I know that there were some comments about how to further specify that. If there are ideas or suggestions, we'll definitely take those. We can also start with kind of this broader reporting element and come back once we understand kind of the analysis a little bit further and see if there are pieces we want to focus specifically on. Jen.
Thanks, Cassie. So we did comment on this, and we appreciate the language change. I think, again, you know, where it comes in under, well, did you take out the language then on requiring, like, I think the reference to 743A is confusing in 168 because it's, you're pulling in the QTL analysis. So we want, like, is that what you're asking for in this rulemaking, or are we sticking to the NQTL analysis? Is that, like, I think there's just confusion there. Because the QTL analysis, the quantitative treatment limits, we do in our other filings.
Right. So one of the data elements in the statute is the specific findings, conclusions of the carrier under subsection 2 of the statute, which is the NQTL analysis, demonstrating compliance with ORS 743A 168 and the federal mental health law. So this is to be responsive to that data element and provide clarity on kind of what that means. Happy to take suggestions if other folks have kind of ideas or of how to report that better. But that was the intention behind that language.
So, okay.
I think it's referencing the analysis that's already done, and I think it likely could probably be kind of a summary statement and kind of talking through how any policies or procedures have been updated to maintain compliance with the federal law or in the state law.
So are you talking about cost sharing? Because that's a quantitative treatment limit. That's quantitative.
It's the non-quantitative treatment limits.
Okay, so, okay.
Gary.
Hey, Jen, are you trying to, what I'm hearing is do we want to propose to remove the 743A168 and just stick it to the federal in QTLs?
That would be helpful for us.
Is that what you're trying to, okay.
Yes, I mean, like, or just clarify that you only want non-quantitative treatment limits because there are quantitative treatment limits in 168. So let's clarify that you only want NQTL analysis.
Yeah, so it is.
I mean, that's the statutory authority for the rule. So we want to make sure that we're complying with that.
Right. So I did add NQTLs in that section. It might be stuck within all those words, but that is further specified in 5.
No, I see that, and I'm just in section. Okay, so 6.1, it says updates to behavioral health coverage documents and policies to reflect coverage requirements specified in ORS 4743A 168-2C. So is that, because our understanding is that still includes QTL. So, Gary, go ahead.
I was just saying, I didn't know if, how big of an impact it is if we just took it out, Cassie, the 168 reference there, because you're going to pick it up later on, like Jen was saying.
Yeah.
Just thinking, because I can read it the same way as Jen is okay, you got NQTLs under the federal, but then you're broadening and saying the whole statute, which is, it seems duplicative. It's QTLs and financial and those other two stuff.
Tim, you have interest.
Yeah, I mean, I know you may be bound by what you can and can't do by what's in the actual statute, but I don't think anyone's intention in this bill passing was to have them reporting additional stuff on quantitative treatment limitations and financial requirements. So I don't think anyone's interested in seeing that. So I would hope there'd be a way that you could specify that that's not what's requested here.
Or again, I agree with Gary, just remove it.
Just the reference to ORS, the rest of it's.
Just the reference, yeah, sorry.
Okay.
Unless they want to, I'm fine with removing all of 5.
I don't know if we'll remove all of it, but we'll definitely consider removing the reference to the ORS to make that more clear.
Thank you.
Mm-hmm. All right. Any other thoughts about the providing descriptions number 5? All right, seeing none, we'll move on to the other data and information necessary to assess compliance with the state and federal mental health parity requirements. We'll start with the telehealth claims in 1. Any feedback on this language? Dan.
I am confused by B. In differences in the median maximum allowable reimbursement rate for telehealth claim related to care, behavioral health or medical surgical. So I'm not sure what's being compared there. whether you're asking us to do the analysis once for in-person and then do the same analysis separately for telehealth, which would seem redundant, and I'll explain why in a second, or anyway, it doesn't make sense to me, particularly given that House Bill 2508 requires that we pay the same for telehealth that we pay in person. So to me, that would eliminate the need for any separate analysis of reimbursement rates related to telehealth versus in-person. And I would think we should be able to lump telehealth and in-person rates together just as one reported set of numbers.
I think that makes sense if other RAC members are in agreement. My intention with this was if there were any differences between a telehealth, like if it's a telehealth visit versus another visit. And I think the context of knowing that the bill was passed to make those the same between a telehealth visit and a kind of in-person office visit. So we can look at removing that from part of the reporting requirements. All right, anything else with telehealth? Okay, we'll move on to the compliance piece with the state law. So ORS 743A 168. We did keep kind of this compliance reporting because these are going to be questions that we would ask to evaluate compliance with the law and will be important to know how the law is being implemented. I think those will be questions that legislators and other stakeholders ask through this process. And so wanted to make sure that we capture some of that compliance piece here in this reporting. Any questions, comments, concerns with this language? Chris.
Yeah, thank you. Just a quick question, which is, again, one of the important pieces to NAMI is the criteria for non-level of placement decisions being publicly available and available to members on request. There's a very large caveat with that as applicable or as applies to copyright law. And just this isn't necessarily suggesting to put in a rule, but how does the division foresee ensuring that that information is readily available and that it's not being onerously denied to at least members making that request?
Yeah, my thoughts with that comment that you submitted about having that information publicly available is that we could, in the next iteration of rules, further specify what that means for it to be posted publicly. If that works for you.
Yeah, moving that to later, I think it does. It's a thorny issue because there's proprietary criteria out there, and I know there may be a carrier or a vendor that's going to hide behind copyright law, and then just working through that in a manner that makes sure that the law is followed will be important to us.
Yeah, thank you for that. Any other thoughts on this section? All right, hearing none, we've reached the end of our rule text. Want to open it up, I guess, to see if there are any kind of general comments or things that we've missed within this rule language that any of the RAC members want to bring up at this time. Gary.
Yeah, it may be for Tasha, but when does the division kind of plan to get a draft template out to carriers that would be asking all this information?
So, great question, Gary. We've been working on that behind the scenes as this rulemaking has been going out. I also am going to be working on the network adequacy report draft template, and my goal is to have both of those out to you guys by probably late December so that we can have comments in January. I think we may be able to send out early drafts earlier than that, but I don't want to overpromise for Spencer and I. So yeah, more to come during industry communication this month.
Okay, yeah, that's just the earlier, just because our programming folks like to get an idea of where they're going and they can start setting that up. Thank you.
And Gary and everybody on the call, actually, as we kind of work toward that, one of the things that I do with my templates and stuff that I put out to the insurers is I have a meeting with the insurers and I invite the insurers programming people or whatever to be on that call to ask the questions that they're going to have, and that would also be occurring in this case. So, you know, I'd want to get any of those last minute questions out of the way to make reporting as easy as possible.
Thank you.
Jen.
Just along those, you know, that discussion, Tasha, do you, and so I just want to clarify that both templates that you're looking to finalize will be complete and finalized by 1/1, correct?
Probably by 2/1, but yes, if I can make it happen by 1/1, I will totally push for that. And Spencer and I can talk after this meeting about timing. The unfortunate thing is we haven't been able to hire the positions for this yet. So I am.
You'd be willing to push the deadlines back then because of the template. I mean, like that just really reduces the time that carriers have to put that.
I don't think we're going to be willing to push the deadline back this year, but I am stepping in while we get those other folks online so that you guys can have that information as early as possible. And Spencer and I will absolutely over communicate with your guys' data teams. Any questions we have or any issues we have, just like we try to do on other data calls and stuff.
So are you willing to take kind of like, you know, give insurers maybe a safe harbor if something's not clear, because it seems like you're reducing the amount of time that we have to produce the information by not extending the deadline and then providing it after 1/1.
Before you guys get super concerned about this, let Spencer and I talk. I think that we'll be okay. And what we can do is we can have a conversation, and when we follow up with the templates in email with Cassie, kind of following up on this call, we will have that laid out for you. So I don't want to overpromise right now. We think we could have the templates done by 1/1, but there's a lot of other stuff going on, so I don't want to overpromise.
Just to follow up on that, we would just ask that you, if you're not done by 1/1, that you allow carriers to submit via the federal compliance guide. So.
Thanks, Jen.
Gary, is your hand still raised? Or okay, just want to make sure. I forget that sometimes too. It's easy.
I was intrigued by the comments from the lady from Illinois.
Them are fighting words, buddy.
So we'll do our best to work on those templates. I know Lisa and I have been involved in that process as well. And we'll make sure to be communicative to this group. I know Tasha mentioned our industry communications. That's a regular meeting that we have as a division with our insurers, but we'll make sure to also include kind of communication to this group about the templates once we get to the point where we can share those.
That kind of brings me to a question or kind of an announcement, Cassie, not to steal the thunder, but Starting in first quarter 2022, yeah, we're in 2021 now, so 2022, we are going to be doing provider communication meetings similar to how we do industry communication meetings. And so that information, Jesse O'Brien and I have been working on getting out and working on kind of planning those meetings and scheduling those meetings. So I know I just talked a lot about industry communication, but I will also, there's also going to be a provider communication meeting that the division has coming up. So great segue, Cassie. Thank you for letting me plug that.
Does that mean the DFR is going to start regulating provider billing practices? Because that would be great news.
I believe that meeting also includes some of us as advocates too, so it's beyond just providers.
Yeah, likely, yes. Yeah.
Yeah.
Yep.
Melissa, you have your hand raised.
Yeah, I just had a question, and I think you may have already answered it earlier, but I just wanted to make sure. So we're still going to be engaged in the rulemaking process past the March 1st deadline when the first report is going to come in. So if there are some issues there, then we can make revisions, because I'm just kind of thinking back to the SB 860 experience and how things in the report didn't quite come out the way that we were hoping. So just wanted some clarification on that.
Yeah, so I imagine that we will still be engaged in rulemaking on the other pieces for House Bill 3046. I know that there's quite a lot that is there, and kind of want to provide that time for adequate discussion and kind of conversation about those provisions. And so I think if we do run into any issues with this first round of reporting, that there will be an opportunity for us to clarify these rules, because they'll be under that same scope of House Bill 3046. Hopefully we got it mostly right for all of our sakes, but I do know, I'm very familiar with, when you're first starting reporting of something new, that you might not get everything right the first time around, just when you actually put it into practice. So
thank you.
Mm-hmm. Okay. Well, this will not, just to reassure folks, if you do have any additional comments to provide on the discussion draft, you can send those to Lisa and I, and there will be another opportunity to provide comment through the formal rulemaking process. We will have a public hearing, and we'll take both, comments at that hearing, or also written comments through that process. So by no means is the comment period over. There's still plenty of opportunity. Dan.
Is there a particular date by which you would want us to send additional comments?
For the discussion draft, I will need to check with Karen on when we need to submit this to Secretary of State's office, because I think if we need to make any adjustments, it'll be based on that timeline. But we can.
So yeah.
If Karen, if you need time to look that up, we can send an email after this meeting with when we would need those comments by.
Okay, let's do that. So we're giving out the right information. Yeah.
Great.
For the dates. Okay.
Okay. Yeah, so we'll follow up after this meeting, send an email to you all about when we need to have those written comments on the discussion draft by, to give us time to make any adjustments before we kind of launch the formal rulemaking process. Okay. So I think with that, oh, Gary.
Yeah, just to clarify in regards to the NQTL templates, just because my people are wanting to know, as soon as possible. Do we know when you'll put out your final recommendation, or where you're going to go? Because you're going to have a fixed template. It sounds like we're not going to have flexibility. And so we're just
Yes.
trying, if we need to switch now, we're going to switch now.
Okay.
And that's what we're trying to get ahead of.
So we will have a fixed template. I think I need to have a conversation with Tasha and Spencer as we kind of talk about this. You know, if it's possible, we will get that out. We could get that out sooner since there are pre-made templates already available, than kind of creating our own template on the other data elements. But I'll need to talk with them about what works best for their team and the reporting.
Okay, yeah, the state specific stuff's not, it's the NQTLs. And that's because we've gone down one path. If we need to make
If
the
you need to
adjustment,
pivot, yeah.
then I want to do it now because the holiday season, and this will come due
Right.
March 1st.
Yes, of
And
course,
then
yeah.
have you heard if OHA is doing the same as you for theirs
So
reporting requirement?
we have been in contact with OHA. I'm not certain about like their process of like if they're going to follow the same reporting requirements that we are. I know they're very similar, and there might be some OHA folks in this meeting. I know they've been following our work. Their timelines are 3 months later than ours, so I think they'll be likely engaging in this work soon. And we've been having conversations since the CCO piece and the commercial piece are, you know, relatively the same. There's differences, but you know, they kind of follow a very similar reporting structure. So
yeah, I'm trying to keep my eyes open for their rulemaking if they're going to do it. So thank you.
Yeah. If I hear anything about their rulemaking, I will let you all know and send a message, because I imagine we might be following along kind of what they do on their end, or providing feedback as they go through that process. But we have been kind of in communication with them to make sure that there is some type of consistency, hopefully, if that makes the most sense for the CCOs in the commercial market.
Great, thank you.
Mm-hmm. Okay. Any other questions, comments, concerns? If not, we'll open up the public comment period and see if there are any RAC members or interested parties that would like to provide public comment. Okay, not hearing anyone, but if there is any interested parties who would like to provide public comment, you can submit those comments to myself or Lisa or Karen, and we'll make sure to send those out to the RAC members. All right, we are on our next steps, which is not another meeting today. I forgot to edit that out of the agenda. So we will wrap up these reporting requirements, this piece of the rulemaking, and transition to kind of the next component of House Bill 3046, which will be all of the rest of it, which is quite a bit. Kind of my plan is we'll schedule out some meetings knowing that the holidays are coming up, but that we want to start those conversations now so that we can keep moving in this work and give enough time for the process to happen. We likely will take a break during February because many people on this call, I'm sure, will be very busy with legislative session when that comes up. And then we'll kind of keep chugging along. So we'll probably schedule another meeting for the RAC to get together to start kind of these conversations at the end of next month. And we'll send out some regular invites to just hold on your calendar for us to have a conversation and to continue this process. Any questions about those next steps? In addition to the additional RAC meetings, we will communicate to you all about the kind of formal rulemaking process for these rules so that you can provide your input or comment at the public hearing, which will be open to everyone, not just RAC members. It'll be the wider public. All right. If there's nothing else, I really appreciate all of the time spent on the kind of providing the clarity for the reporting requirements. I know that there are several RAC members that are excited about this next phase for rulemaking. So I appreciate you hanging in there while we provide the clarity to the insurers so that we can get reports on March 1st. And really appreciate all the comments from all stakeholders and all parties in this space for kind of crafting rules that make sense to help provide clarity for the reporting. Yeah, so thank you all, and we will give you back 10 minutes and hope that you have a great rest of your Thursday.
Thank you.
Thank you.
Thanks, Cassie.